Hello, everyone. Just wanted to check. Can you guys hear me? Aves?
Yes,
मैम
yes, we can
आवाज आ
hear
रही है।
you.
Okay,
We
perfect.
can hear you, Mariam.
Thank you, Dr. Sadia. Thank you. Thank you.
अस्सलाम
Walaikum salam. Um, I think Lubna and Narendra also here. Am I right?
Yes, they're here.
Okay, good. Mariam, I just emailed you my presentation as a backup.
Dr. Sadia, I've saved that already. Thank you.
Good morning. Good afternoon.
Good afternoon, Professor Arul Kumar. Nice to see you.
Nice to see you. Good afternoon. Good afternoon.
Thank you so much for joining us. What time is it in UK right now?
It's 9:50, close to 10 o'clock.
Oh, okay. So not too bad for you, I guess.
No, that's fine. Yes.
Yeah. So how's COVID treating you in UK?
Oh,
We're
it's
all
pretty bad, pretty bad. More and more places are coming under lockdown now.
yeah. I guess that's the trend all over that we're having, a little bit of an upsurge here as well.
Okay.
Well, yeah, I heard your talk like about 6 months back when it had just started, and you were saying nothing's happening for another year. We have to learn to live like this. So now, what do you say?
We have to live for another 6 months like this till the vaccines come into force.
Hello, how are you?
Fine,
Sir?
thank you. Thank you.
And Farooq Jaman, how are you?
Yes, I'm very well. Thank you very much.
Farouk is looking the same. He hasn't changed.
Sadia,
Assalamu alaikum, Dr.
Walaikum
Samina.
Assalam.
So nice to see Dr. Farooq
Yes.
as well. Yes.
Hello. Yes, Sadia. Thank
We
you.
don't see each other anymore, so Zoom is the only way now.
Yes. Zoom is the only way. But thank goodness for this also, that we have this medium which brings us all together. As a matter of fact, I'd say in some instances more frequently than
Hello,
perhaps we would.
is my presentation can be seen?
Yes, we can see.
Yes.
Okay, thank you very much. Okay, see you.
And we can hear you clearly too. So nice.
Hi,
And we
everyone.
also started seeing
Hi.
Lubna as well.
Lubna, your hotel room seems okay. It looks very bright. You said.
My hotel, I'm actually, taking the big plunge, traveling across Pakistan after about 7 months. Because
Okay.
I'm doing this training. So I was in Balochistan yesterday. I'm in Karachi today. Then I'm going to Lahore, then to Islamabad, and then back home. So I was looking forward to this meeting actually because I was all alone in my room and I said, at least I'll see some familiar faces and exchange a few notes on COVID.
That's good.
Yeah.
Got to be careful traveling around.
Yeah, I know, but then this needed to be done, and WHO was teasing me, and Pakistan seemed to be doing well when we were planning this. And then just as I started out, they said there's going to be another surge, but by then it was too late.
So, Dr. Arul Kumar, do you think we're going to have a vaccine? Honestly, I'm
Well,
very
the
skeptical.
two vaccines are coming for FDA approval by December. So at least these two vaccines. And the good thing about these companies is actually they are going ahead and manufacturing these vaccines even without approval, so that they are so confident about it. But there are other vaccines other than UK, USA. There are vaccines from Russia, from China, from the different parts of the world. So we have some hope. The question really is actually about the efficacy and safety. Which vaccines? If you have 5 vaccines in the shop floor, which one do you select? That's the question.
Yeah, and I was reading they never got a SARS vaccine. So I don't know. I'm not very hopeful somehow.
Well, the question about its efficacy, as Arul said, is also there. How long that immunity lasts.
আমি শেয়ার করছি তো শেয়ার থেকে বেরিয়ে আসবো কেমন করে স্ক্রিন
Yeah,
শেয়ার
I think
এরপরে আবার এই শেয়ারে ঢুকবো
GG production seems to go down in 3 months.
বলি দাও
But the T cell immunity seems to last for about a year.
দিয়েছি ওই যে আমার প্রেজেন্টেশন
About
দেখা
a year,
যাচ্ছে
like the flu vaccine.
আমাকে দেখাও না
Yeah.
আনন্দ অনিন্দ আমাকে
Good
দেখো ও
vaccine.
এত তাড়াতাড়ি দেখার বুঝতে পারি না
They do this
এটা শেয়ার করছি
chimpanzee virus
হ্যাঁ
vector
ও
vaccine.
সেটা বলবে তো
And that seems to
তাহলে
be
এখন কি
good
করবো
for
এটা
Rift Valley fever and SARS and MERS and so on. So I think there's hope there.
Good afternoon, everyone.
Yes.
Assalamu alaikum.
Assalamu alaikum.
Assalamu alaikum, Firdausi. How are you?
I'm fine, thanks.
Assalamu alaikum, Dr. Firdausi. Lovely to see you.
Thanks. It's
And
really
hey,
good.
hello. Good afternoon.
Good afternoon. So we are starting in 6 minutes time. Am I right?
Yeah.
That's right.
Sadia, I think I have joined from your ID. So ask the person to change the name.
It will
It's
change.
actually,
It will get
Oh.
changed. Anyone who comes onto the screen comes with the name of Sadias.
oh really?
Yes.
I did.
Yeah, even I was under your name and then I changed it
Yes.
manually.
She is
It
the
has an
person
option
that
to
I
rename.
changed,
What she forwarded, you are
Oh,
joining
I
the
was-
forward.
Hello.
I
You
was-
join with
How are you?
your email.
Narendra,
Hello,
you're wearing a-
how is your
Rock Arul, how are
how
you?
your granddaughter
Sometimes you would like
She
to
is
sleep
fine.
in your sleeping suit,
Okay.
except for
No
these
problem.
surgical scrubs. Every time we see Narendra, he is in surgical scrubs. And not that he's wearing
Lubna.
those for protection, he's actually working with so
Actually
I hope
working. And then
you do get some
today
time
is
to
a
sleep.
today is a tough day. It is a festival and everything. So everything is going on today.
Yes.
And then to
I
read so
think,
much.
Narendra, you sleep
so
in
much
your
to
scrubs
answer.
now.
Yeah. Diwali
You have to
and
read so much to
Dussehra
answer
and,
SPG.
yes, all those things. Good.
Oh, now I become Professor Trina Fariduddin. Faridun.
No, you
I'm
don't look
Professor
like her.
Firdausi.
That's not you.
Firdausi, you
Lubna?
should be able to change your
How are
name,
you,
clicking
Lubna?
on the name.
Hi, I'm great. How are you?
you said that you are in dark room, but it doesn't look like that.
Well, I'm trying to get under this lamp so that I can see. There is a
You don't have
ceiling
to
lamp,
crouch that
but I'm
much.
trying
Dr.
to-
No,
Lubna
you're
generates so much light.
Lamp.
That's fine.
You don't
That's
need
okay.
lamp.
Lubna generates so much light. She's a bulb herself.
No,
Yes.
I'm trying to make you notice my COVID look. See, I've gone gray.
Oh my God. Farooq sir, I want to discuss something very important with you. Basically, we are going to have our EC meeting on 24th of November. But I think we had an unfinished agenda of this, our constitution updating. You are the chair of that committee. So should we organize a Zoom meeting of your committee before the EC meeting?
This is for whom is it? This is addressed to not to me, I think.
Starting him off.
Oh, Farooq Zaman, yes.
Okay. I'll discuss with him later.
Firdausi, you can click on the name and you can change it yourself. The name.
Okay.
You click on Trina's name, then it'll come as a menu which says rename, then you can rename.
Let me try.
Click on that name.
Working.
Hello, Rubina.
Hello, everyone.
So,
How are
hello.
you?
Hello,
So nice
Rubina.
to see you.
How are you?
Thank you. I'm good. Thank you.
Thank you, sir.
Okay, that's good.
Yeah.
Ratna Shiri, how are you, Ratna?
I'm fine, thank you.
Narendra, you are in OT?
No, I've just come out, just finished. So I was hurrying, so I didn't change. I said I'll sit like this one. Just
What
finished.
Is it puja? What is going on? Durga Puja?
Yeah, puja went in the morning. We had a good puja, nice puja. Ashtami and Navi both together. So
yeah.
When that Durga has that mask, when that Durga has the mask,
we are having the mask. All of us are wearing it. In our house, it is very traditional to do that puja, and Jaideep cooks food for herself for about 100 people. So it was. I'll send you pictures on the executive group or the fun group for you all to see. So we had a good time. We could get up 5 o'clock in the morning, cook food.
I think Durga with her family will be infected.
Well, Ravan is definitely infected.
She will take it away. Or she will take it away.
I hope so. Hope so, really hope so. Because it is getting out of hand. It's getting so bad. Especially doctors and nurses getting and being very seriously ill and dying is the worst.
The saddest part of it. But
So finally, this book is out, Dr. Arul.
Ah, good.
And it has come out very well.
Okay.
With Rubina, finally it is out. With Dr. Arul's forward and all, and it is available for sale on Amazon and everywhere. The authors, of course, will get a free copy as soon as we can start mailing.
Yes, that's good. That's good news.
And the new SAFOG, this one is also out. Just yesterday it came, the hard copy. So I think we need more articles from all the countries, because we have from Indonesia, Malaysia, and even so it is international, but the SAFOG countries should be sending articles and reviews in the Journal of SAFOG. So, and it is on the verge of getting indexed. It is already indexed in the bibliographic listing of many, but Index Copernicus, I think by the end of this year, we should be getting indexed also, fully indexed. We are already indexed. We are already indexed in so many.
That's good. Congratulations.
So, Prof. Arul, I think, can you write a guest editorial this time? Women's health in COVID times.
That looks a very hard task for me to answer.
You've been talking about it everywhere.
Yes. Yeah, maybe you had to think about a special issue on COVID for South Asian countries, Southeast Asian countries, or SAFOG countries.
Yeah, that's what we are planning.
That's good.
So I guess we can start now. It's 2 p.m. Should we start?
Yeah.
Yes, please. Yes, please.
Good morning, everyone. I welcome you all to the SAFOG session SOGP virtual conference. We will be talking about a very important topic, sustainable development goals, and how do we see it from a South Asian.
I cannot hear you.
Can you hear me now?
Yes, better.
Okay, so before I start, I'd like to thank each one of the participants from different countries and locally, as well as the panelists, the chairpersons, the patrons, and the speakers who've spared time to be here today. So before we move on, let's just go through the norms of the group. So first of all, you all will be muted during the session. This is for the participants, basically. They can ask their questions using the question answer box. They can find the box through their Zoom menu and type in their questions, and we'll come back to them after the session is completed. This is how they will submit their content-related questions. They can also raise their hands in case of any queries on the chat window. E-certificates will be submitted to them after the feedback form has been submitted. So we hope that you can enjoy the session today. So before I move on, let me introduce Professor Dr. Yusuf Latif Khan. He's a Program Director, Endoscopic Courses by MIXU, Clinical Director, Hamid Latif Hospital, Lahore, Professor of OBGYN at Raj Latif Medical College, Lahore, Pakistan. He's the IVF Consultant at Life Center and Secretary General, SAFOG. Over to you, sir. He'll be the moderator for today's session. Thank you.
Welcome everybody, and it's indeed a pleasure to invite everybody to this forum. It's done under the banner of SAFOG and of course SOGP. We have a good mix of seniors and juniors coming into this forum and talking about a very pertinent problems which we're having over here right now. So before I go ahead, it's my duty to kind of introduce to the panelists. Sorry, for the patron first. And first of all, I would like to invite Professor Sir Alukumarum. Sir, thank you very much. I know it's pretty early and it's always pleasure to see you and have your input. You've been patronizing SAFOG for as long as I can remember, and you've always been there to help us and support us whenever we needed you. Thank you very much, sir, for joining us on this forum. And in the end, we will like to invite you to say a few words about this, all the panel discussion to that. Thank you, sir, for joining us. I don't think so I need to introduce Sir Alukumarum on any forum anywhere in the world. Even I think my kids also know about all of him, what he's done. If I go through your CV or anything, I think we'll be ending up doing nothing else, just remembering you. But still, thank you very much for joining and doing that. Next, please. Next is Professor Rashid Latif. I think I just had a talk. He's kind of busy somewhere. There's a chance maybe he'll kind of join us. Otherwise, Professor Rashid Latif, he's a professor emeritus of obstetrics and gynecology. He's a founder member of SAFOG, and he's the ex-president of SOGP as well. He's been doing that, and he's also kind of patronized us whenever we need him. Next, please. So, it's also my pleasure to invite Madam Firdausi Begum, and we found out her very fast, not very fast, but I think the fresh picture of her recently from the net. And she is the president of the SAFOG right now. She heads the department in Obs and Gynae in Ibrahim Medical College, and she's also the president-elect of OGSB, which is the Society of Bangladesh. Thank you, madam, for joining us, and as usual, guiding us wherever we stand right now. Next, please. So next is our country SOGP president, Madam Razia Kurejo. She's always been also part and supportive of this, and whenever we got in touch with her for a support forum, SOGP forum, she's always very kind and helping us. And these are kind of relationships which are developing between SOGP and SAFOG, which kind of make everything better. And I think in the end, whatever we are aspiring to do, that is kind of make a woman's health more accessible to everybody and improve their care of it. She has, as I said, she is the president of SOGP. She's worked in the Department of Obs and Gynae, Jinnah, postgraduate PGMI, Karachi, till 2013. And she's now the professor on BU MDC forum from 2013 till now. Thank you, madam, for supporting us and joining us on this forum. He's one of my mentors, Professor Farooq Zaman. Right now, he's the dean of Rashid Latif Medical College. And I have the honor of being, not only me, I think a couple of other people sitting on this forum being his students. And he was the past president of SOGP as well as the past president for SAFOG as well. Thank you, sir, for coming over and joining us again. So the purpose of this session was that it's the brainchild of Dr. Meena, starting from that. So our main focus was when we went back and looked at the MMR and when they were started off. And unfortunately, we did not reach the targets as they were meant to be. But what it did, the MMR thing, was it laid down a foundation for the SDGs, which came out in 2015. So they kind of changed that into more practical aspect. So this was the SDGs which came out, they're total in 17 with a couple of others, their subsets as well. We only going to focus, we can't focus on everything else, but we're going to only focus on maternal mortality rate and the contraception and gender-based violence. In this forum, we'll have 3 talks, each for these MMR, for contraception, and for gender-based violence, which is significant for SDG. And then, going to that, we're going to have a great, I suppose, hearty panel discussion with joining us from, I think, India, Pakistan, Bangladesh, and Sri Lanka as well, and Afghanistan also. So we'll have this, and the purpose of this session is basically to learn from each other, those who have achieved these targets and those who are on the road to reach these targets and those who are not. So what worked for anybody, what didn't work for anybody. So these are the kind of things which we're going to do that, and we move on. So basically the idea about this was out of this slide, which MMR targets we talk about, is that remember that by year 2030, which is about a decade from right now, no country should have a mortality rate of about 140. So let's see who are on the right track and who aren't that. And if somebody asks me what is the single most issue about all this, is probably is the population, which, as you can see, India being the number 2nd right now, Pakistan heading towards 6th, and probably maybe crossing over to 5th sooner or later. And of course, Bangladesh, which is worked very hard on this, is still on the 8th position. So out of the top 10, we are top 3 countries in the world of the whole of the population, which probably would make up something like maybe 1/3 or 2/3 population of the whole world. So if we talk about MMR, as you can see, Pakistan has done some, try to make an effort from that, which means that we are from MMR, we have reduced that from 276, which was in year 2006 and 7, we've come down to 178, but still we are very far away from achieving the goal which we meant to be. But India has done wonders. I think hands off to them, to the kind of population, but it's all the effort of all the people, I think, working there. They've recorded fall in MMR from 437 from 1992 going down to 122, which is, I think, a miracle in 2015-17. And hopefully they are right on the track. And one of the things was the role of Mahanta initiative. And I would invite Professor Narendra when he comes over to talk about this and what it worked about in our panel discussion. So these are kind of total fertility rate and CPR, as you can see, are all other countries. They are kind of working or struggling to now most of the things, except for a few countries, especially Sri Lanka. If you can kind of see that, they are, I think, there because of their education and everything. But these are the figures which we would like to share. So it's my honor to invite the first speaker, which will be Honorable Professor Rubina Sohail. She is the professor in Service Institute of Medical Services, which is located in the heart of Lahore. And I had the honor of being working there with Professor, under the supervision of Professor Farooq and with Dr. Rubina in the same department. And she's is the Vice President Pakistan Menopause Society right now. She is the ex-SAFOG president as well. Her area matters a lot of them, but out of one of them is, I think, gender-based violence. And she is going to talk about the social norms and behavior leading to gender-based violence. It's not an easy topic, and I'm sure she's going to do justice on or whatever she's going to talk about. So I'm going to invite Professor Rubina Sohail. Madam, the forum is all yours.
Thank you very much, sir. Just let me share my screen and then I'll start. Good afternoon, ladies and gentlemen. Yusuf has already given a lot of elaboration of what we want to do today. And I'm going to talk about the social norms and behaviors which lead to gender-based violence. The outline of my presentation will go like this, that we are going to just touch upon the current situation of gender-based violence. What are its implications? what are the possible causes, and what are the norms and behaviors that lead to gender-based violence, and do we have a way forward, and what are the kind of interventions that we can do to make sure that these kind of situations don't happen. I request all of you to please mute your mic so that there's no disturbance in the presentation. This is just to acknowledge so many of the gender-based violence victims and survivors, and to just share the importance and the pain that you feel when you look at them and the kind of atrocities that have been done with them. And before I start my presentation, just to reiterate my point, I will share with you a story. And this is taken from a movie clip from a Pakistani movie. So if you bear with me for only a minute, I would just like to share a clip with you.
और कितने दिन चुप रहेंगे? तुम मुझसे कोई बात क्यों नहीं कर रहे? इसका मतलब मुझे तुमसे झूठ बोलना चाहिए था। हाँ, बोल दे कि झूठ, ताकि मैं शक में तो रहता हूँ। मुझे तो आदमियों ने खराब किया। एक को मैं छोड़ूंगी नहीं और दूसरे के साथ रहूंगी नहीं। मैं सिर्फ तुम्हारी बीवी नहीं, तुमसे अलग एक पूरी इंसान हूँ।
So this was a movie which was produced by a Pakistani producer a couple of years ago. And just to show you that this kind of awareness is also creeping in Pakistan, it is being taken up as a subject of importance. Now, violence against women is not only happening in Pakistan, it is happening all over the world. And according to statistics by WHO, about 1/3 of the women all over the world in their lifetime experience some kind of physical and sexual violence. In Pakistan, the issue is underreported. But despite the fact that it is underreported, the statistics look like this. 93% women experience some form of sexual violence in public places in their lifetime. 70% of Pakistani girls experience intimate partner violence. 62% of reported victims were only between 10 and 19 years of age. And 73% of the accused were identified as people who were very close to these girls, family, friends, relatives, and neighbors. So this is the extent of the situation in a country where we say that this subject is not being discussed as much as it should be. I was doing a workshop, and in the workshop, I asked the participants, which were mostly female, and I said to them that how many of you have ever experienced any form of violence in a public place? And nobody raised their hand. There were about 50 people in the class. And then I raised my hand and I said that, have you ever been pushed and shoved by a man when you were going through a street? And all of a sudden the hand started rising up. So this is the kind of discussion that we do on gender-based violence. So what are the consequences when we talk about gender-based violence? And I'm sure the group is well aware, and so are the participants. But the issue is not only of physical effects of the problem. The issue is of psychosocial effects that it produces. The issue is of sexually transmitted disease. Issue is of unintended pregnancy. Issue is of transmission of HIV. And issue is of long-term depression. And when we look at these issues, we always look at the survivor of the violence, that this happens to them. But what happens to the people around them? In terms of children, if they are small, they're always, their minds are always affected by these kind of abuse, and they also become participants in abuse sometimes later on. They do not receive proper health care, and sometimes these children of abuse victims are going to suffer from depression, from schooling problems, and from other issues, so on and so forth. And they might, as well as adolescents, be replicating what they saw in their childhood. Now, the question is, and which brings us to our talk, that what are the reasons for violence against women? As a general rule, if you look at it, it is basically always gender inequality. But there are other things happening as well, which might be feeding in. So all these points that I have raised over here are actually interacting with each other in some form or the other. Gender inequality, poor rights situation, inequality in financial status between the man and the woman, then all those social norms which we're going to talk about in a couple of minutes, the overall influence of poverty on the situation, and total lack of emancipation of the women. All these factors are the factors which are actually preluding to gender-based violence. The biggest driver of violence against women is gender inequality, as I said before. So this inequality is in terms of power, resources, opportunities and values between male and female genders. And this is the root cause of violence which the girls face. Now, if we want to eliminate violence against women, we have to make sure that this patriarchal system has to be changed. And this can be changed by social, political, and changing the economic position of our women. Now, when we talk about gender-based violence, we talk about gender inequality. When we talk about gender inequality, we have to look at the ways and means with which this gender inequality is affecting our women and girls. And because these are the drivers which create an underlying social context in which violence is going to happen. So there are 4 key ways in which this can happen. Number 1 is when we condone violence against women and we think that there's nothing wrong with it. Number 2, when men's control of decision making and limitations to independence in public and private places. So men are the decision makers. That is the second point. The third is that when male peer relations that emphasize aggression and disrespect towards women. And the fourth is rigid gender roles, which are stereotyped and they construct separate masculinity and femininity norms. And generally, the men and women are bound to stay in those norms because of our social setup that we have. Now, if you look at it, there are various kinds of norms. But if you look at it, one norm. So if we say that it is common for men in our family to beat their wives, it is considered to be a norm and it is a typical thing going on. So if we start thinking that beating the wife is a norm, then this is the kind of behavior that we are going to inculcate in our generations. If you're sitting amongst a group of friends and you say that women are the primary bread earners in our household. So this is the norm that you are sharing, that women are supposed to be the breadwinners, then men can just sit at home and enjoy the luxury of having food provided to them. So these social norms are absolutely important in producing a culture or a situation in which violence can happen. And believe me that these norms, these social norms are so powerful. They are like invisible legislative systems because these are binding our expectations to behavior. So if these are the expectations that we have, that men are the leaders of the house and men have the right to beat their wives, then the norms that are there in the families are also going to be the same and the behaviors are going to be the same. So these are the norms that have to be looked into. Now, there are positive social norms and negative social norms. And our job is to look at those negative social norms which are promoting harmful behavior or disrespectful behavior towards the women. So if you look at negative social norms, if young people don't find work, we say they are going to typically engage in criminal behavior. If it is acceptable to drink alcohol amongst friends, then this norm is going to be there in the society. If it is acceptable for teachers to physically discipline their pupils, it is acceptable. So what we are going to do with the norms is that we have to look at the norms and we have to convert negative norms into better positive social norms. And these positive social norms are going to create a culture in which women are respected, girls are respected, they're given equal rights, and then gender-based violence can be averted to some extent. So whatever kinds of behaviors are there, norms actually help in strengthening those behaviors and reinforcing those behaviors. And our job when we look at the negative norms is to have a construct of positive norms which are going to be imbibed, which are going to be repetitive, and which will become the future social norm, and that is how gender-based violence can be controlled. Now, these social norms are creating situations in which violence can often happen. So what are the kind of things? One of the things is that it is a private matter whether the women are treated with respect or whether they are subjugated to violence. Women's lack of independence, again, is an issue which is going to lead to violence. Male sexual entitlement of doing whatever they want to in their home and they have the right to do everything because they are the leaders in their household. Then culture of honor and purity, or the social norm of honor and purity, that if a girl is subjugated to rape or any other form of violence, it is a matter of honor of the whole of the family. As you saw in the clip of the movie, that when the girl was raped, it became a matter of honor. And the family did not want to share what was happening with the girl and not talk about it in public. Then the sexuality of the youth, a taboo in many cultures. And then the lack of acceptability of divorce. Now, these are the perceived male and female gender norms, which are actually perpetuating violence. For male, it is acceptable, or with masculinity, it is acceptable that there should be male dominance, there should be aggression, there should be sexual entitlement, there should be toughness, and they have a power over everybody else. For females, a typical femininity for South Asia is that the women should be docile, they should be caregivers, they should be submissive, they should do their job of childbearing, they should be domesticated, and they should have a reserved sexuality. So just look at the difference, and till the time we are not going to convert these norms into one norm for both genders, things are not going to move for us. Now, if you look at the social norms which are contributing to gender-based violence, so men have a strong sexual appetite, so they can go and rape anybody. Men have power in public and private lives, and they are beyond reproach. You cannot blame them for anything. This culture or this norm is contributing to gender-based violence. For women, women's important role is to cook and take care of the family. They're not supposed to be making decisions, and it's not the man's responsibility, but rather the woman's responsibility to avoid a pregnancy if it needs to be avoided. In intimate partner situations, it is an acceptable norm. Violence is a family matter. It is not acceptable to seek divorce if your partner is violent. And good mothers are going to bear the violence because they want to keep the family together, and they still have to be obedient and docile despite the fact that their partner is violent. Regarding sexual violence, girls have to ensure that they don't tempt the men. Men are entitled to free sex. If a woman is raped, she is blamed for putting herself in a situation where the man could come and rape her. If the woman is a sex worker, she is blamed if she is raped because they think it's a part of her job. So this is the kind of situation that is happening. And our job is that how do we change these social norms? So the good news for all of us is difficult to change, but the social norms actually can be changed. And it is our job to change these social norms into positive norms and create shared expectations in which male and female gender remain the same. Now, if you look at changing the norms, it is only not changing the norms which is going to help us. We also have to ensure that when we try to change the norms, there has to be a legal and policy framework with it. We have to make sure that there's socioeconomic development of women. Their religious and political ideologies work for protecting the women against violence. And when we join these together and we get programs which are going to change the social norms, then these will be implemented with other initiatives to change the culture or to change the norm. Now, there are various ways and means and strategies to transform these norms around violence against women. These include socioeconomic empowerment, mobilization of the community, parenting programs, peer education and training, school-based programs, advocacy, and so on and so forth. And in a recent event of rape, which happened in Pakistan on the motorway, there was a lot of advocacy and there was a lot of voice created. And it is the creation of voice along with other things which is going to help us. So there are 4 key ways which I'm going to talk about, and I'll leave the rest of the discussion for our panelists. That the first thing that we need to do is first identify the harmful social norms and say that this is a harmful social norm, because it is time to change the norm and it is time to change the social environment. So we need to have enough formative research by which we can identify those factors which are going to support violence. The second thing is that we need to change the social expectations. So we need to weaken the bad norms, and we need to make sure that we bring in new norms, promote them, and we provide opportunities for engagement of these norms in order to bring a lasting social change in the norms. The third is that the new norms need to be publicized. They need to be role modeled. The benefits needs to be propagated, and we have to reinforce the new norms or the positive norms in order to make sure that we are able to develop a sustainable situation in which the new norms will be accepted by the public and the general environment will be changed. And the last thing is to reinforce to make sure that these norms are reinforced again and again. And by reinforcing the norms again and again, we are going to create a situation in which the new norms can result or can help us in protecting our women against gender-based violence. I don't think that it can ever be eliminated, but gender equality, creating new norms, reinforcing the new norms needs to be done. And we need to have, along with these, a policy of change and legal reform has to be accompanying these change in the social norms. Now, when we talk about these norms, one always thinks that maybe it is something easy to achieve, but believe me, it is something which is very difficult to achieve. And the things that we are going to institute or the steps that we are going to institute at this stage will have impact many, many years later. So we have to develop policies which are short term, medium term, and long term. So if you look at it, time for environment change, even short term means we are talking about round about a period of 5 years if we want to produce a short term change. For a medium term change, the time duration increases to about 15 years, and long term means for more than 50 years. It means for us that whatever change we are going to produce or whatever new norms we are going to create and support them with policies, with equality of men and women, all these have to be done sustainably for years and years and years. And only then, when the generations will change, only then we will have a situation we will say that we have gender equality, we have the new norms in place. Because if you look at women coming to us, they talk about things which were done 60 years ago and they considered them the norm. So the norms are very difficult to change, and we have to have short, medium, and long term solutions to make sure that we are able to produce a sustainable change in our environment. So before I end my presentation, I'm just going to re-emphasize on 3 points, which I think that I've done a lot, but I would still like to repeat them again. Number one is that the norms need to be addressed. Norms need to be identified. There needs to be a solution for the norms in the short and long term duration of time. We have to work, join hands and work towards gender equality, because without gender equality, the readdressal of norms probably will not be possible. And we have to make sure that our women are financially independent. Financially independent women are actually moving towards gender equality. They are able to put new norms in place and make sure that these norms help them achieve gender equality. I will end over here and I'll just share with you a picture of our FIGO group and committee who works for violence against women. And if there are any questions, please share them with us so that at the end of the session, we can answer all your questions. Thank you very much.
Thank you, Dr. Veena. As usual, you concise this huge topic beautifully in allotted time. And the one thing which I think I would take out from your this talk is the word norm. And I think this norm word has to be changed because it keeps on changing from generation to generation, and we have to find new norms for everybody, for our generation and for the next coming year. We'll, as you said, we'll take the questions in the end. My next speaker, it's my honor again to invite Dr. Sadia Ahsanpal. She's also been just a phone call away whenever we needed her, and either it is somewhere in Pakistan or out of Pakistan. She is the chairperson of Maternal and Fetal Health Committee for SAFOG, and she is the consultant in OMI Hospital and Concept Fertility Center in Karachi. She's the ex-vice president of SOGP as well. And she's going to talk about another interesting topic, which is maternal mortality and behavior change. So I hope after her talk, we have some this behavioral change in all our doctors and this coming in. And over to you, Dr. Sadia, for next 15 minutes.
Thank you, Dr. Yusuf. So I will, behavior change is not that easy, but anyway, I will give an introduction to people who are not familiar about. I wonder how many of you have been involved with values clarification workshops. I'm sure some of my colleagues here must be. Without further ado, I will, you've already been introduced to the SDGs, and we're basically, they're all interlinked, but we're focusing on health, gender equality, and how it affects our women. And Rubina has given a very, very good introduction to it. And before I start and give you some statistics about Pakistan, I just want to share that the role of women or their status in the society, not just in Pakistan, but I feel in this whole region, is very similar. They don't enjoy, mostly they don't enjoy equal rights. And even though at least in Islam, women are supposed to have equal rights and even have inheritance, which goes back to centuries. But in actual fact, it doesn't happen. So there's a lot of disrespect there as far as women are concerned in this whole region. So we are, from the sixth, we've moved on to the fifth most populated country in the world. Our maternal mortality ratio has come down in the most recent analysis of the Pakistan Demographic Health Survey from 276 to 186. But nevertheless, it's not good enough. And this is from Verbal Autopsy, a review of the maternal deaths in the review. This has to be further dissected and broken up, and that meeting hasn't happened yet. Now, the contraceptive prevalence rate is 34% in the latest survey, and instead of going up, this has come down. In the previous survey, it was 35%, and disappointingly, instead of going up in 2018, it was 34. It came down 1%. On the other hand, the unmet need for contraception has also decreased. So it's a bit of a paradox. It was initially 25%, then 20%, and now it's 17%. So what is happening here? So there is more than 50% of pregnancies are unplanned. 34% of these end up in unplanned births, and 54% end up in terminations. 5.6% of maternal deaths are attributed to abortion-related complications. Now, we do think that this is an underestimate, because most of the time abortions are not reported, or we have what is I would call dishonor killings, and especially if it happens to be a single girl, she's very likely to die at home or be murdered by her own family members because she got raped or got pregnant and she's single, unfortunately. So what has happened in the last 10 years, this is from a population council study in 2004 and 2015, the abortion rate, instead of going down, has more than doubled. So, it seems that women are using abortion as a method of family planning. Rather than use family planning or contraception, these women are using abortion. Now, what is the profile of these women? They're the women who have induced abortions, they are over 30 years or older. They're from rural areas, mostly uneducated, poor, and have 5 or more children. 696,000 women are treated annually in public health facilities and private teaching hospitals for complications resulting from unsafe abortions. Now, we all know interventions to reduce maternal mortality. These are well documented, evidence-based, and abortion-related deaths can be reduced by contraception and post-abortion care. And somehow we are lacking there. We're not doing our job well enough. But all these interventions are dependent on functioning health systems with well-equipped hospitals and trained providers. And the simplest, and I don't know if we can call it the easiest, but the most effective method to avoid maternal death is contraception. If you don't get pregnant, you won't die. It seems pregnancy itself is a very dangerous thing, at least in our countries. So 1/3 of maternal deaths can be saved just by family planning, by delaying motherhood. Don't get our daughters married off too early, or even if they get married off. I mean, it's illegal to get married before 18 in Pakistan. But even if that happens, because that does happen a lot, the law may be there, but the culture is to get the daughter married off as quickly as possible, especially in poor households. And so even if you do that, they should at least be taught contraception, and pregnancy should be delayed until they're in their early 20s at least. Birth spacing and avoiding unwanted pregnancies and unsafe abortions, and stopping childbearing when they have reached the planned family size, and this often doesn't happen. Now, unfortunately, in Pakistan, although free contraceptives are available, uh, the most effective contraceptives, modern contraceptives with the lowest failure rate are least used. For instance, look at this: pills 1.7, injectables 2.5%, implants 0.4, IUDs 2.1. So, don't even count withdrawal as a method. So, the most effective methods are not being used. And before I go any further, and there is behavior change required there as well, because our providers are not themselves have barriers to providing modern contraception, and we'll come to that. So before I go any further, I just want to share this story, which maybe some of you might know about. Amrita Shergill was a famous artist from Lahore who also belonged to Delhi, I think. And she died from a botched up abortion. So she and her husband happened to be a gynecologist. So when he was away, apparently she did have an unsafe abortion, and he did try to save her life, but she died, unfortunately. This is way back, in the 40s. So a lot of us don't know this, but these things are just not talked about. There are, if you start taking histories of women, um, even in your own family or your friends, there will be women who've had a termination of pregnancy for some reason or the other. And when a woman dies of an unsafe abortion or complications related to it, we have actually failed her 4 times as healthcare providers. Number one, we didn't give her contraception at the right time. Number two, when she did have an unplanned pregnancy, she didn't get emergency contraception. And number three, uh, there were no safe abortion services for her. And number four, when she did seek emergency services, there were no adequate emergency services. So this is the state of affairs which exists in most places where unsafe abortions take place. Now, most of our public and our healthcare providers are not aware of the abortion law in Pakistan. I didn't know about it until I myself attended a values clarification workshop about 13 years ago. Now, abortion is legal in Pakistan to save the woman's life or to provide necessary treatment. Necessary treatment. There is consensus among the major Islamic schools of thought regarding the concept of ensoulment at 120 days. The abortion law, which we sort of read when in med school in our jurisprudence books, was basically a colonial British law. Remember, we were colonized for 200 years, and most of our legal system still has laws which are British laws, which the British themselves have changed way back in their own country. So in 1999, this law was vetted out, and then it was changed to conform to Islamic principles or the Sharia in 1999. But most of us don't know that, neither did I. And most of our doctors do not know about the FIGO resolution on conscientious objection either from 2006. And this is recognizing that physicians have an ethical obligation at all times to provide treatment, benefit, and prevent harm for every patient. To behave ethically, practitioners shall provide public notice of professional services they decline to undertake on grounds of conscience, and refer patients who request such services to other practitioners who do not object to provision of such services. Provide timely care to their patients when referral to other practitioners is possible, and delay would jeopardize patients' health and well-being. And in emergency situations, provide personal objections. So most of us are not aware of this. More than 95% of practicing doctors and health workers in Pakistan are unaware of this. We conducted a survey of over around 330 gynecologists from all over Pakistan. This included professors as well as trainees. And this was anonymous, and 205, meaning 2/3 of them, said they did not provide any abortion services. So when asked, if you do not provide abortion services, do you refer your patients to other skilled providers? Then 1/3 said yes, about 81 didn't mention, and 1/3 said no. So there are many misconceptions. It's not just about abortion, but about other contraceptive methods as well. Contraception itself. A lot of people think it's against Islam, which is not true. And there are misconceptions about ICDs, that it causes abortion, infection, infertility, migrates to other organs, and against the religion because it is an abortifacient. Again, not true. Then we had a lot of debate about misoprostol, which I see, and most of my colleagues see, as a life-saving drug for PPH. And we had to do a lot of advocacy to get this drug registered in Pakistan. Nobody was interested in registering. Like the year 2000, I presented a paper on misoprostol in the SOGP conference and at FIGO, Washington. And at that time, I was told that, you shouldn't be doing this. People will start misusing it and start using it for abortion instead, and terminate their pregnancies. So my answer to them was, I really don't care what they do, what women do themselves. What I do care about is not seeing women with their loops of bowel hanging out from an unsafe abortion, and then being up all night trying to save her life with the general surgeons. So what is better, if she pops 3 or 4 pills and solves her own problem? I really don't care. Or if a doctor or midwife uses it, I really don't care. I think what is not right and unethical is not to help these women. And I've really changed. I didn't think like this before, but it's my patients and my clients, as they say, they have changed me. And we were subjected to such kind of, we even went to the parliament. This drug was registered as ST-MOM, which stands for Save the Mom. And Professor Sadka Jaffrey was the patron for this drug for PPH prevention. And then we were very fortunate, very soon WHO and I think it was WHO or FIGO, that they recommended that it's okay to use it for incomplete abortion as well. So that really helped us. And really in my practice, I hardly have to deal with PPH anymore. So the other thing is hormonal contraception. A lot of myths and misconceptions related to it, and values clarification required there amongst healthcare providers as well as the general public. These are evidence-based figures. that hormonal contraception is actually good for you and prolongs your life. And but even doctors are very surprised that, oh really, oh really, oh really. So that's and then the weight gain thing, oh mote ho jayenge. So the answer to that is it's eating that makes you fat, not the pill. The statistics are that in Pakistan, um, over 50% of women are overweight or obese, and it's the same for the men. So less than 2% of women are on the hormonal contraceptive pill, and men don't take contraceptive pills. So why are they obese? That's my question. So we've been doing values clarification and attitude change workshops for doctors and other healthcare providers. This is really needed in reproductive health issues, not just abortion, but there are so many, even adoption has a lot of connotations which people have not gone into. It's not that easy, not that simple. Then gender issues, child abuse, sex education, all these things that Rubina mentioned, they are all linked. And when we specialists and skilled providers do not help these people, they end up in the back street clinics. So we have to engage stakeholders for behavior and attitude change. Uh, what we do is we tell them, we make them go through exercises to examine their own personal values, attitudes, and actions related to contraception and abortion and other stigmatized RH issues. We facilitate provision of contraception, abortion, SHRH care, and within the legal framework and their own personal beliefs and values. We don't want to go against our own beliefs and values. I will not do something that is going to make me feel really, really bad or guilty afterwards. You know, I may help to save somebody's life once, but I can't do it as a routine if it's really clashing with my own personal belief and turning me into a nervous wreck or a psycho myself. So it has to be, you have to be happy in what you're doing. And you have to clear the myths and misconceptions with honest dialogue and interaction, examining alternate values. Okay, you think like that, but what does the other person think and why is that other person thinking like that? And the first exercise in this behavior change is to think about your own values. We're all so busy in our lives, we don't have time to think. So we have to engage ourselves in honest self-reflection. And this is like a hour and a half exercise that we go through very quietly. And at the end of it, you know, somebody or the other in the group will say, today I met myself. Then there are activities like Four Corners, where participants understand their own and then the other person's beliefs. They are faced with their own double standards. This is done in a very clever way where it just comes out, you know, through an exercise, and they learn to empathize and understand how personal beliefs can clash with their professional responsibility. And then we have a very powerful activity of a case of a young girl who commits suicide. And we engage the participants and make them experience empathy. So this is a story of a young girl from a village who comes, very bright girl who comes and studies in the city, and she graduates, gets a good job, and gets engaged to this young man who likes her and she likes him. But one day he rapes her, and she ends the engagement. And being very simple, she doesn't realize that she is pregnant. And of course, coming from the background she did, she couldn't face her family or the society. She attempts, she goes for help and doesn't get help from the doctors twice. And eventually she attempts abortion several times, doesn't happen. And in the end, she commits suicide. So this story is nothing new. I'm sure most of you in the audience, or at least the gynecologists here, would have dealt with a case like this. And in fact, during one of our sessions, one of the doctors, she broke down and she stepped away and she said, "This is me. This is my story, except that I had died 20 exercise. I feel that I'm alive again somehow." So at the end of it, we asked them who is responsible for her death. And most people say, oh, it's the doctors. Then surprisingly, a lot of people say she herself is responsible. Then some say her fiance, and some say her family and parents, because they didn't give her sex education or didn't prepare her for a big city. And of course, culture, honor, society. And surprisingly, which made me very happy, was in a couple of workshops, 2 or 3 people have said the fiance's parents. Now, why the parents, the fiance's parents? Because they raised such a monster. What kind of values did they give him that he thought that he could do this to a young girl? So there you are. So does the behavior actually change? Okay, we can go through 1 day, 2 day, 3 days of self-evaluation, self-reflection, and examining alternative values. But do we really change? So I know you won't perform my abortion. Now this is something said to one of my colleagues in Karachi, a senior gynecologist. She shared, because she doesn't do abortions. So her patient came to her and she had an unplanned pregnancy and she was requesting an abortion. So she said, I know you won't perform my abortion, but when I come in emergency with complications from unsafe abortion, you will manage my case, won't you? And that is true. That is exactly what is happening. The same patient that is being turned away by a skilled provider returns in emergency, and then you are dealing with her perforated bowel. So what do we find in our pre and post-op workshop surveys? It's a very short time. 1 or 2 days is hardly any time to make you, change, or people don't really change. But strangely enough, when confronted in the face with what happens, we do see behavior change. There is significant increase in the knowledge at the end, and there's a positive attitude on the workshop survey form. A professor shared this. I have been providing safe abortion services to rape victims, no questions asked, thinking I was acting against the law and religion, but performing it as my professional duty. I feel better now that I know that it wasn't against the law or religion. I support the provision of abortion services as permitted by law. I can clearly explain my personal values concerning abortion. I can respectfully explain values concerning abortion that conflict with mine. Now, these are all statements that they put down at the end in the conclusion. There's respect for women's rights and empathy. It is not illegal, and it's the right of every woman that she can have safe abortion. I may not agree with the patient's action, but I can respect her feelings. As far as professional responsibility, my ideas about abortion have changed because my responsibility is superior to my personal beliefs. And one doctor, on the first day of her training, her employer said that she has resigned, and she was the only skilled provider in the area that she worked in some remote area of Balochistan. So the first day she went through the training, and The next day morning, she announced, I'm taking back my resignation. If not done by myself, then refer to safe hands to provide services. And as far as religion, Islam, and abortion is concerned, I want to explore, most people say this, I want to explore abortion's Islamic point of view and the practice, what is going on in the Islamic world. And I want to explore the conflict regarding law, religion, and culture. Now, what we don't realize, and during these workshops, people realize that why are we Muslims or why are we of any other faith, whether we are Hindu, Muslim, Parsi, Christian, whatever, we haven't really converted to that religion. We were born into families who had that religion. So most of us, at least where Islam is concerned, we have not studied, we have not understood our religion. We read it in Arabic without understanding it. So the first step I would say is to start to at least read the Quran in Urdu or English or whatever language that you understand, and you will find how easy it is, how it's an instruction on life, on how to live your life quite simply. So there's nothing complicated there, but we've made it complicated. So we've learned some lessons. In the end, weekend workshops have been successful in improving providers' knowledge, attitudes, and behaviors. Significant increase in understanding in the legal framework. And there's a sense of professional responsibility, which includes, and they start seeing it as a woman's right. They give us recommendations, things like there should be more content related to Islam and abortion. The law, rape, contraception should be discussed in greater details. But there's just so much you can do. I mean, you can have a week-long workshop on religion and still not agree with each other, and that's fine. Or any of these topics, actually. And it helps to have a mixed group of participants, including doctors, nurses, midwives, and non-clinical providers. You see, and of course, should be conducted for providers in areas having feudal systems and cultural stereotypes. Now, when you have mixed groups, you have these, non-clinical people, and you have these policy makers who have never seen a victim of unsafe abortion or a victim of rape or a child abuse case. We see them. We see what happens to these women and these children, and we see what happens to their families. So, and a little bit of us dies, and these women. So it's good when we interact with those people, and those people see a face to the misery, that they're not just a number, but there's a story behind each and every one of those women. So the recommendations that come up, and we already have these email groups and WhatsApp groups to support each other, and should be adapted to use with policymakers, community leaders, media personnel, medical students, teachers. In fact, there are medical schools in the US, and some it hasn't started in Pakistan, but we do feel that in final year med school, there should be a values clarification workshop for these students, and ethics thrown in as well, so that they come out much more confident doctors who can practice in a comfortable way on subjects, especially which are just not discussed in our society. But there's a problem. There are hardly any VCAT trainers. We've trained so many, and hardly anyone wants to do it. It's time consuming, and it's emotionally very draining, very tiring. There's no money in it. So, nobody wants to be. So I wish there were more people helping me. How can providers help? They can update themselves about the law, about our own subject, and evidence-based advocacy materials and messages should be generated. They should be assertive and strategize for dealing with conflict. and understand the effective use of social networks, we have to adapt to a new environment. And we've all learned, haven't we? We're using Zoom now and many technologically advanced things which we didn't before COVID, and COVID has really taught us, hasn't it? Some things. So improving women's health and saving lives by ensuring access to contraception and safe abortion services, gaining respect from clients, colleagues, and others. And we can influence administrators and policymakers to get change for the betterment of many women. But I do believe, as Rubina said, may take 5 years or 10 years or 15 years. I do believe women can change society, but they are their own worst enemies. A daughter-in-law suffers at the hands of her. Surely she can raise her son with the right values to be better than his father. But no, she does exactly as she was treated. She does the same things to her daughter-in-law, the same demand for the male child. And so it goes on and on and on. Maternal mortality will decrease when we start valuing our women in our society, when we give them equality, education, sex, and life skills education. The mother eats leftovers after feeding her whole family. This is in upper class as well as lower social class. Lack of contraception services and universal health care. This has to improve, you know. She's an unpaid worker at home, whether from a rich household or a poor household. And in the rural areas, she works in the fields as well, while the husband is on a charpai smoking his hash or hookah or whatever it is. The inheritance also, she is often deprived or bumped off or not married in case the, you know, the inheritance goes out of the family, or married too early. There's the dowry, there's the exchange wedding, tribal feudal customs, stigma associated with being single or divorced, and of course this polygamy business and in Muslim countries. However, Tunisia is a Muslim country and they abolished polygamy way back in the 60s. So, and their prime minister did that and said it's written in the Quran, which it is, you know, you can interpret it yourself. So, and then of course there is working women, they're also stigmatized. If she dies or is infertile, she can be easily replaced with a younger fertile girl. And the cattle are more precious than the mother or wife. And the honor seems to lie in the woman, you know, curse. And I feel in the subcontinent, at least, these men with mustaches, you know, ये मोच की लड़ाई होती है, क्या होती है? Their whole manhood is in their mustache. And the manhood is in subjugation of the women in his family. This has to change. So hundreds of women alive at sunset never saw the sunrise this morning. Some died in labor, some died of hemorrhage, some died in the painful convulsions of eclampsia, some died on the table of an abortionist trying to terminate an unwanted pregnancy. This I'll share with you. This is from one of my values clarification workshops in Muzaffargarh. This is a lady health worker who really wanted to attend the training and she had a 6-month-old baby. Now, how do you discuss these serious things with a baby? And I was asked, can you allow her? She's come from very far. So I allowed her and the baby behaved very well and she was able to attend. So I just love this picture and her. And in the end, I'd like to thank you for your attention. And I'm really looking forward to this cup of tea in Hunza with all of my friends, and maybe we can have a retreat there as soon as COVID is over. Thank you.
Thank you, Dr. Sadia. It was, as usual, indeed a great pleasure to listen to all the concise laws of generally focused on Pakistan. And I'm so glad that I'm not wearing a mustache right now. And further ado, I think we'll have this panel discussion. So it's indeed a pleasure to invite Professor Samina Chaudhary. She's one of the very soft-spoken professor from Bangladesh, and she's the president of Obstetric Gynecology Society of Bangladesh, and she's also the president of Endometriosis Society of Bangladesh. So she's gonna talk about on the contraception, what has actually worked for Bangladesh. So, Madam, it's over to you, Professor Samina. Yeah.
Greetings from Bangladesh. Is it audible to you?
Yes, madam, we can hear you.
And you can see it?
No, I can't see.
You can
We can't
see
see your, we can only see you, we can't see your slides.
Okay, sorry.
So you have to share the slides. If you want, I can do it from here.
Okay, you do it, but you have to do it quickly.
Yes, sir. We will just take a second.
You go to first slide, please.
Madam, just give us a minute. ये चल रही मेरे पास नहीं आ रही. Can anybody see the slides? Dr. Lubna, you were up, I think.
No, we can't.
Can you see it?
No, we can't. We can't.
You have to first open the slides and then share them. So open the slide on your laptop. No, it has to be first open. It will not open like this. So first minimize this, open the slides on your laptop and then share. You will not be able to open like this. It will not open in this. Close this down. It will not open like this. Minimize this, open the slide on your laptop and then do the sharing. Open your presentation on the laptop. First open the presentation, don't share first.
You have to unshare. Stop sharing and then share.
Stop sharing.
Stop sharing हो गया. अभी उसको presentation को open करो. Open the presentation, then share. No. It will not open like this. It will not open like this. Don't share first. First open the presentation separately. First open the presentation, then share.
Slide sharing e jao. Ei je ekhon slide share e dao.
Yes.
You can see
now it is good.
Hello, now we can
Yeah,
see.
দেখা যাচ্ছে. Yes, you can.
Done.
Okay. You can see it?
Yes, we can see.
দেখা যাচ্ছে, we can see it.
Okay, I will operate it. Assalamu alaikum. Greetings from Bangladesh. First of all, I want to give thanks to the organizers for selecting me as a speaker in this prestigious webinar. Dear chairperson and my dear colleagues, welcome to the presentation on contraception, what works for Bangladesh. You know that Bangladesh is a country which is situated in the delta of Bay of Bengal, a small country with a big number of population, and the population density is about 1200-1500 per square meter. The background, Bangladesh had made significant achievement during the last decades in reducing population growth and improving maternal and child health. Bangladesh Family Planning Program has depended on a large cadre of female outreach workers, female welfare assistant, family welfare assistant going door to door to provide information, motivate clients, and provide commodities. The program has used mass media to stimulate a change in the attitude about their family size. Trend in fertility estimation for Southeast Asian region, you can see the Bangladesh is in the red line, and you see that there is a good curve during the last 2 decades, but still there is a stagnation at 2.3 during the last 20 years. Proportion of women of reproductive age who have their need for family planning satisfied with modern methods. And you see the red one, Bangladesh had 72.6%. The history of family planning in Bangladesh, it has evolved 11 phases started from 1953, when it was in Pakistan, it was the then East Pakistan. And at that time, there was two phases programs. But after the liberation, or after 1971, during the 1972 to 74, first program was initiated, Integrated Health and Family Planning Program. After that, MCH-based family program and multi-sectoral programs. And in this way, there was 11, now it is going the 11th phase, that is 2017 to 2022 Health Population Nutrition Sector Program. And in this program, there was 7 operational plans operated by Director General of Family Planning. They are as follows: planning, monitoring and evaluation, and management information system, procurement, storage and supply system, and also mother-child, reproductive health and adolescent health by DGFP, clinical contraception services, and also family planning, field service delivery programs, and information, education and communication. You see the success of family planning program in Bangladesh. There is increasing contraceptive prevalence rate, but decreasing the TFR, total fertility rate. And you see the current use of contraception, any modern method, it is 54%, pills 29%, injectable 12.4%, and condom use is low, 6.44%, and others are very low. And the family planning targets of 2020, it was TFR 2.2. But during this COVID period, these 9 months, we couldn't give that much attention to these women. So I don't know whether the target was set, we could achieve it or not. This is really a challenging issue. Young married women from the community were deployed as outreach workers and trained to conduct home visits with women offering contraceptive services and information. That is one very important issue. And also there is establishment of family planning clinics in the rural area to provide clinical contraceptive services. Women's education is a key to success. The percentage of women using contraceptive is lower among the women without any education. And over the time, all education shows an increase in the trend of use of modern contraceptives, and most recent years showing the stagnation among uneducated women. Women's education, its impact on use of modern methods and traditional methods, still it is going up. But there was definitely some problem faced by the programs. Then use of mass media was an important issue. There was harassment of female outreach workers during that time, and these workers faced threat to violence by the villagers and primarily the women. Thus, 2 of the country's most famous writers, including Humayun Ahmed, who was no more in this world now, but he was very much popular personality in our country, were asked to create a storyline that would show the value of the outreach workers' efforts in both urban and rural environment. Another program was created, and the heroine named Laila, the docu-drama, has given a tremendous effort, and they are very much popular character in the society. And after that, the effect was very much swift and positive, and community accepted them. In fact, that is inspired Similar initiatives in Kenya, Tanzania, Brazil, Mexico, India, and other countries also. But definitely this challenge is increasing because of this COVID situation, and especially the early child marriage is increasing, and high unmet need is there, low use on long-acting reversible contraceptive and permanent method, unwanted pregnancy and abortion, and quality of services. Two key population group with high burden of unmet need for contraceptives now we are facing. And 47% of recently postpartum women are not using any family planning method, but 92% want to wait at least 2 years before having another child. And this unmet needs is increasing to 17% to the adolescent girls. And nearly 1/3 of these women from 15 to 90 years have begun childbearing, and contraceptive discontinuation is going up with this adolescent, and also they have got very low knowledge about the contraception. But there are some opportunities. National Action Plan on Postpartum and Post-MR and PAC Family Program is going on, and increasing trends in the facility deliveries, but which was hampered during this 9 months period of COVID pandemic, and structural program development in operational plans and deployment of midwives at the Upazila Health Complex and FWCs. There is wide range of methods used in family planning issue. You can see the network of family welfare assistant in the middle. You can see the community engagement. They are going to doorstep of their client, and they are also accountable to upper level of FWV and Upazila Health Complex and MC, the mother and child welfare centers. Mode of service delivery in the community level, the domiciliary visit and satellite clinic and community clinics, and they provide counseling, antenatal care, postnatal care, and also short-acting contraceptives and community sensitization. At the union level, after that there was upper level, union level, there was family welfare center, and they also distribute these commodities, and also they are they can give the MR and MRM services and post-abortion care. And they give also services for nutrition and other for general patients services. And at the Upazila level, that is the sub-district level, there was all these together with emergency obstetric care services is there. And in the district level, they provide all of these services. And this shows our strength of our health infrastructure. Removing religion and cultural barriers, it was really a problem, but how we have tackled this? There was domiciliary services and community participation and behavior change communication activities. And we have also included involvement of Islamic leaders and IC material for Islamic leaders. You see one family welfare assistant counseling for using contraceptive at their home. Demand and supply model of domiciliary services. On the supply sides, they provide the provided services and also demand generated. And on the demand side, counseling and also awareness development is there. And you see another FWV, family welfare visitor, she is giving services in a satellite clinic. It is in the courtyard of one the renowned person's home. It was done weekly. Contributing factors of the National Family Planning Programs. They are the Family Welfare Assistant and Union Health and Family Welfare Center, and public-private partnership is also important issue, and effective contraceptive supply chain management is important. Enabling factors of National Family Planning Program, there is strong and continuous political commitment towards family planning issue is very important. improving female education and increased female engagement in the workforce, and decreasing early child marriage and decreasing under 5 mortality is also important. Now, innovations in some our national family planning program is use of ICTs, that e-learning course and e-toolkits, e-register, and social media involvement, and sexual and behavior change communication, digital archives. Incentivization of transportation cost, waste loss, and also they are giving the interest fund. From there, they can spend the money in any hospital. Community engagement, involvement of religious leader is also important, and imam and elected community leaders is very important, and civil society organization engagement is important. You can see one Union Health and Family Welfare Center in the village. And now, what's about our SDG? Whether we could reach that, that is really challenging in this situation. If we consider on this issue SDG 3 target 3.7, under that indicator 3.7.1, the proportion of women of reproductive age who are satisfied with modern family planning methods. The baseline data of 2014, it was 72, but we have to reach by 2030 100%. Is it possible? We have to work for more work we have to do. Indicator 3.7.2, adolescent mothers' birth rate. It was in 2014, it was 113 per 1,000 women now, but we have to reach about 50 per 1,000 women. Challenges on the SDG goals achievement, that is human resource capacity, availability, motivation, and retention is very important, and it is really a challenge. And financing high out of pocket expenditure is also an important issue. Data management and quality of data and regional disparities is there. Innovative approaches to address these challenges, public-private partnership, community participation, involvement of private sector, and fund mobilization, increase GDP allocation for health, and expand health insurance scheme. And now I want to highlight some OGSB's role in family planning project. OGSB FIGO PPID initiative in Bangladesh. I am very much happy to say that Professor Sir Arul Kumaran, and he was the leader, and he gave the leadership during these last 5 years, and this October it came to an end, but it's a very successful program, and our OBGYN people are directly involved in the PPID postpartum IoT project, and government now agreed that they will continue this program, and already Sir Arul Kumaran, you will be happy to hear that already government has put it in their operation plan. And these are, in that project, during these 5 years, 15,562 insertion was there, and total number of providers were trained at 2,617. And also good number of counselor was there, and they are ultimately they are our asset in this society, and we want to continue their services. And thank you, sir, for your valuable contribution and leadership. Thus, I want to say family planning, a life-saving intervention, improves health, it prevents 30% of maternal death, about 20% of newborns death, reduce more than 66% unintended pregnancy, and reduce safe abortion by 40%, and also promote gender equality, enable adolescents to finish their schooling, reduce poverty. For every $1 spent on family planning, and there will be $14 be saved. And now I want to say that these women of Bangladesh who received these family planning issues, we need to salute to them. They made the change. So salute to Bangladesh women. Thank you very much. And thank you. the participants for giving me the patient sharing. Thank you very much.
Thank you, madam, for a concise overlook of the Bangladesh and how their success story. And now we move on to our second part, which is the panel discussion. And indeed, it is a group of, in Urdu, we call the Guldasta, which is a bouquet of Azim gynecologists around this SAFOG country. And on top of it is, of course, Professor Lubna Hassan, one of my favorites. She has been the president of SOGP, and she's the past president of SOGP, sorry, and she's the vice president of SAFOG right now, and she's currently working in Peshawar, Lahore. Welcome, madam. Next is ever active everywhere you see, whenever you pull up social media, is Professor Narendra Malhotra. And it's always a pleasure. It's just been this COVID situation where we haven't met for a while, but it's always good to see him always there. He's the managing director of Global Rainbow Healthcare and ART Rainbow IVF, which is, I think, spread most of the in SAFOG area as well as going up to Dubai, I suppose. And he's the president in SAG. He's the vice president of SAFOG, and she's the past president ISAR, ISPAT, IFUMB, and FOXY also. So welcome, sir, and hope to talk to you. And it's always a pleasure to see you. And I'm surprised you're not in PPE today. Oh, so the next one is also one of the main persons or key factors in running in our SAFOG region and contributing in this SAFOG organization is Professor Shyam Desai. He is Professor Ops and Gynae Mumbai University for the last 30 years. He's the president FOXY in 2005, and he's the founder, deputy secretary general, and secretary general SAFOG, and vice president SAFOG. At present, he's the chair International Relation Committee of SAFOG. Welcome, sir, to this panel again. And from Afghanistan, we have a good friend, Dr. Tarina Firadon. I hope I pronounced it right. She is from MD from Kabul Medical University, and she is hold a couple of degrees over here, and she's mainly working in Kabul as a trainer specialist in Malalai National Hospital. And we get some information from what is happening in Afghanistan from her as well. Thank you, madam, for joining us. And last but not least, Dr. Ratnasari. He's from Sri Lanka, and Sri Lanka is one of those countries who have done wonders for these MDGs as well as for SDGs. He's the president of Sri Lanka College of Obstetrics and Gynecology, and he's the treasurer for SAFOG for, I think, this is the third term or second term running, and he's a member of multiple committees. Welcome, Dr. Ratnasari, as well. So we'll start with this panel discussion. I'll, I think, involve Dr. Lubna first, which is asking her a question. Okay, where do you think this, where is South Asia when it comes to achieving these SDGs, and where are we heading?
Well, the short answer would be that we have a long way to go. But as we've seen these three presentations and just focusing on what was said, I think a lot has been achieved. But remember, we are only 5 years into the SDGs and have another 10 years to go. It's not to say that, we should prolong the whole process. But we still have the same challenges that we faced during the MDGs. And many of us were not able to, even meet the MDGs. So we still have, to begin from there. That would be my short answer to, where we stand. Basically, our maternal mortality and, the other neonatal issues, at least in Pakistan, seem to be budging and coming down. But we must remember that these are estimates. We are still, as a region, really challenged where actual data is concerned. So we have to take these estimates with a pinch of salt. They're very good for comparison. But if we really want true data to impact our, the evidence so that on which to base our strategies, we really must focus on getting better data.
Okay, Thank you, madam. I think it's the data issue which we comes out to. My second question would be to Professor Shyam Desai. So what can we do better to enable to achieve all these goals? Or what do you think we should do?
Before Sham comes in, I think what we can add to Dr. Lubna's is that though some of our countries were well on the way for SDG, but this COVID has changed the whole situation. So with COVID, poverty is going to come in a big way. Overpopulation is going to come in a big way. In illegal abortions, septic abortions have already come in. The contraceptive lack has already come in, and we are faced with a newer challenge. So what we thought that we have 10 years and we will catch up, but the next 2 or 3 years are going to be very, very tough to catch up because all the nations are going towards a recession, and this recession is going to lead to the health budgets being cut, the education budgets being cut, which is a major part of the SDG. So I think we'll have to rethink, the countries will have to rethink the strategy because of COVID.
I totally agree with you, Narendra. Do remember that I think the COVID situation was one thing which has enhanced is the priority for medical health for all over the world. So maybe the health budget might be not cut as much as we were hoping for.
The health budget will be there for infectious diseases, but maternal and maybe contraceptive and all might be just pushed a little bit back. So we might see that and that is what we are fighting with the government of India, that please do not cut this, because if you cut this, then it will double the problem of COVID. So as it is, we're going to face overpopulation, over delivery rate in the next 4 or 5 months. And if the budgets are then restrained and we don't go on the track what India was following about maternal mortality and reducing it so drastically, we might just suffer a setback.
So let's keep our fingers crossed. So is Professor Shyam there?
I think Shyam Desai is unable to join.
Okay, sir, then the next question is over to you, Professor Narendra. Can you share your experience and interventions you put in the place which led to a reduction in maternal mortality in India?
So, like you mentioned that we have a Manyata program. Now, let me clarify, the Manyata program is 16 clinical standards of providing good obstetric care. And this is yet not a national program. It is only for the private practitioners, and it is only right now in 4 states. The 5th and the 6th states are there. So it is not even covering 1/4 of India. The program which the government put in was public-private partnership. So on 9th of every month, because we have this Nau Durga and all the women's health is related to 9. And this happened when I was the president of FOGC in 2008. Every 9th, every woman, any pregnant woman can walk into any obstetrician's room and get a free antenatal service. So that was a major thing which was called as Vande Bhatram scheme, and now it is called renamed by the same government, and very, very effective. So as a private practitioner, now I have to go to a public hospital in the village and give my free services on the 9th of every month. So this was, and then the government for the public sector, for their medical colleges, district hospital, set up what we call as Lakshya. Now, Lakshya is a word, that is a goal. And the goal was maternal mortality 70 by 2030. So this Lakshya involves structural changes in the labor room OT and clinical standards. So it was structural plus clinical standards for bringing out respectful maternity care. Now, this was done for public sector. So we thought, why only public sector? Jepaigo and Merck for Mothers came to us and they said, why don't we do it pilot project for the private sector? So private sector, we called it Manyata. Manyata means a recognition. The word literally means recognition. So we started the pilot project in my city, Agra, and it was very successful in Uttar Pradesh. And the Manyata did not take care of the structural labor room size and etc., but it took care of 16 clinical standards. Patient walks in, how she's talked, how the sheets are clean, what is there in the labor room, the emergency drills are done. and we started training the private small nursing homes into this. Eclampsia drill, PPH drill, anemia drills, all the drills. And that has made an effect in these 4 states, which was Uttar Pradesh, Jharkhand, and now it has gone to Karnataka, Rajasthan, and Maharashtra. The Maharashtra government was very smart and they added Lakshya to Manyata. So they made all the private sectors also make the infrastructure. And with this, they get a Manyata Lakshya certificate. So that is as good as NABH or any accreditation and a government accreditation along with a private. So this program is doing very well. That's one of the interventions. Then we had the 108 and 102 emergency helpline. Anybody could ring in and you get an ambulance in 2 minutes nearest, which shifts. So the delays which were causing maternal mortality, we addressed those. So we addressed anemia 24/7, 365 anemia Bhagao from India. Not very successful, but it is there. We addressed the ambulance or the emergency obstetric care. We trained the MBBS posted at the primary health center to do cesarean section. Now this was the biggest challenge because this legally the MDs and all were objected. Why are you training only an MBBS? But life changing, and they attended the EMOC course, and this EMOC again was done with Jepaigo, and it was very, very successful. Again, from 2008, Dr. Sadhana Desai as president, and I was the vice president of Oxy then when we put in this. So these are some of the interventions. Basically, it has to be a public-private partnership. Because 70% of deliveries in India are occurring in the private sector. So we need to do the private sector.
I think, sir, it's a initiative which is coming in the same manner. I think the Pakistan government is also on the right track. They have made this Insaf card, which is insurance given by the government, and they can even utilize it in private sector as well. In those hospitals, they are recognized. That means with this card, we have to provide them services in our private sector as well. So I think it will kind of go a long way. So Professor Sham is here. So I'm going to ask him, sir, do you think that only the females are the victim of gender biased, what do you call that? Discrimination, or is the male partners are also affected?
Maybe to a smaller extent, but it's mainly the women who are affected by it, because they're at the various stages of their lives. They're always the weaker sex and the less privileged sex. So from the childhood into the adolescence and the motherhood, and subsequently even thereafter, they are the rather discriminated sex.
But sir, as you can see, the females, they are coming up stronger and stronger. When my father was in medical school, there was only 6 in his class. When I went, there was only 50% was there. But now when I go and take their class, there's only about 30% males and rest are females. And all those scared boys are sitting in the corners waiting for the girls to hoot them up. Is that true?
But the lucky boys, that they have a bigger choice. Anyway,
so Yusuf, I want to add here, if I'm allowed to add a line. Sure. It was Beti Bachao, Beti Padhao. Matlab, you save the daughter by educating the daughter. So the daughters have got educated. Everyone, even in the villages, they're doing bachelors and they're doing MA, and lots of them are doing PhDs also. And as you say, in MBBS, there are lots of them. But still, they are not safe. That is the tragedy. So we changed the slogan from Beti Bachao, Beti Padhao. Again, it is a foxy slogan taken by the government of India. It was given in 2008, and the government of India took it 10 years back without acknowledging us. But we have changed it this year, saying Beti Bachao, Beta Samjhao. Save the daughter by making the son understand. So that is what is lacking. And that is where we made a mistake. We taught the girls, but we did not take care of the boys. So it's the boys who have to understand now the value of women and the value of the girl.
Okay, but there are several schemes. There are several schemes that have been put up. One is as Narendra said, the Beti Bachao, Beti Padhao, the one-stop center scheme, the women helpline scheme, and the Ujjwala scheme, working women hostel. So there are all various schemes that have been put forward by the government to enable the women to be less discriminated against.
Thank you, sir. I'll come back to Dr. Shyam again, because there is a problem which I kind of read somewhere about gender-based abortions in India. What do you think is the uptake of you and the general population in India?
Well, obviously, it is something that is not really desirable because it is obvious discrimination against the girl child, and it has to be sort of curbed at all its aspects. So the government of India has enforced a law which says that one cannot have sex determination, and in many centers or in many states, the ratio has now more or less equalized. But in certain states, it is still to be equalized. But it is something which is obviously discriminatory.
Okay, thank you, sir. Now I think we move on to Afghanistan with Dr. Tarina Firdon. Madam, are you here? If she's not here, then I'll go back to Dr. Lubna, asking her, what do you think in the low resource countries like us, we should be doing for these SDGs to come up? How to tackle them?
I think, all over the world, these SDGs are different from the MDGs, where we have 8 MDGs, we now have 17 SDGs, and many of them are interlinked. So the first thing we need to do, obviously finance, always in whatever we do, finance is going to come up. As the others said that, the governments need to cough up more money for social services, but it's social as well as environment as well as economics. And these three have to come. So they have to be sort of now between our ministries and our vertical institutions, there have to be horizontal linkages. Now, many of these things actually don't cost a lot of money. So even if you're low resource, the issue is that it's not just our low resource, it's also that we have not been focusing on public health. Many of our countries have really, we are able to give excellent curative services now in health. Look at the IVF, look at all the other things that have really gone up, all the cardiac surgeries, the plastic. But when you come to, things like maternal mortality, which are multifactorial issues, they have a lot to do with public health. It's interlinked with poverty. It's interlinked with education. It's interlinked with so many factors. So I think what the governments now need to do, and in Pakistan, at least this government has shown its commitment, that it has actually was the first government in the world to adopt the SDGs as their policy through the National Assembly. We also have provincial task forces. So as far as the paperwork is concerned, it's all going very well. And but the resources eventually need to be put in the right place, and we need to build our capacity to deal with these, interlocked things. The strategies have to be multifactorial. We have the Sehat Sahulat card. So we are dealing with poverty with the SARS program. There's the LHW, which is a flagship Pakistani program that did so well in the beginning. But then it is hijacked by the polio drive and by, elections. So, basically you have to come back to issues of governance. So whether you're low resource or whether you're high resource, you have to get your basic structures right. And I think as far as Pakistan is concerned, we seem to be focusing on that a lot more. As far as gender-based violence is concerned, now KP has passed its bill on domestic violence. So although, you can't monitor every home, but if there is a deterrent and there is actually, you can be punished for it, and there's accountability, there will be some deterrent. And we are also trying to raise the sort of age of marriage, which is actually 16 in KP now. We are trying to bring it to 18 like the other provinces. So there's a lot that can be done. Even this collaboration between the family, the population welfare and health. Health for years has been absolved of providing contraceptive services because we had a parallel ministry. So, we keep on going back to our resources, but these things don't need resources. We need to sit and improve our governance and sort of integrate a lot more than we've been doing in the past.
Thank you, madam. I think the take-home message from your talk is the will. The will has to be there, and then the things start falling on. Now moving on to Sri Lanka, Professor Ratnaswari. I would like to, because they are the ones who have done wonders with all these parameters, and I would like to ask them about the contraception. How did they work on this contraception, and what effect they have on their economy and everything on that?
Yes.
Sir, are you there?
Thank you very much. So Sri Lanka actually have a high prevalence of contraceptive acceptance, and it's free of charge. And most of our households, they are belonging to a midwife. He's the primary care worker. So she understands most of the problems at the community level. So she provides, in addition to that contraception, we have the government institutions, 24 hours open government institutions, which are also giving contraceptive freely for the people who are attending. And we have a counseling program, as well as we have added the postpartum contraception to the hospital levels. So we have a better contraceptive prevalence in our country, and our unmet need has gone down to 5.1%. So that is a very good achievement. But I have a fear during this COVID crisis period, whether this will be disturbed and we will have more issues with issuing contraception and the people coming to our places for contraception. So that is a small fear we have in our country, and we have to expand the contraceptive prevalence in addition to what we are doing at the moment. So the Family Health Bureau, that is the government arm of the health ministry, is providing all these necessary requirements for the regions with the health regional directors. So I think in the years to come, we will be all right with the conception in our country. To tell you about maternal mortality in our country, now we are static for the last 10 years. I think we are in the stage of transition from fourth stage to fifth stage. So that is all preventable deaths should be prevented. But only thing is, now when we analyze our deaths, we have seen indirect deaths have overcome the direct ones. So indirect deaths, mostly heart disease, respiratory, the other organ failures. So we have to have high dependence, highly specialized units to manage them. We had deaths with dengue, pneumonia with influenza. Now we have introduced new guidance, guidelines, and education. So we have come down in those cases, but heart disease is still the commonest killer in our region, in our country. Thank you, Yusuf.
Thank you, sir. I think it's again coming back to the partnership between the government and all the health providers and providing them, as you said, even the healthcare LHPs are kind of trained for this thing. And this is the right way to go forward. And it's not only about the money, it's the will, which, as Dr. Lubna said that. So I would like to ask Madam Firdausi, from Bangladesh perspective, where do these SDG there stand, and how are their experience for working their way forward for this SDG goals?
Thank you. First of all, I congratulate SOGP for organizing this session. Very important, not only in the perspective of the SDG, but also in the COVID situation. So basically, the whole region is fighting for SDG, I should say, because our indicators are, I think it's always challenging, because Sri Lanka is up the ladder, but still they're fighting with their standard. But the other countries in the region have to work more, because our indicators are much, much below the satisfactory level. I think all the standards, including the SDGs 3 and 5, which is directly related to our topic, I think the maternal and women's health is challenging. The children, adolescents, women, elderly, and specifically all the clinical services we are mentioning here, which is especially in the public health level. So I think if we say as a sort of statement that the region has to do more. And we, the clinicians, and especially the people in the obstetrics and gynecology who are much more involved with the public health, has lots to do. And as societies itself, because the problems are very specific for the country and the health setup is different. So we can have a basic uniform goal or sort of a tendency or a desire to solve these problems, but each individual country has to do on their own basis. And what I should say that all of us, the societies, the professionals, had lots to do for this. So I'll end with this. Thank you so much.
Thank you, Dr. Firdausi. Now I'll hand over this to Dr. Mariam Iqbal, who is the main backbone of doing all this right now. And she's going to do the comments from this chairperson and the patrons. Over to you, Mariam.
Thank you, sir. Thank you, everyone, for a wonderful talk. So now we'll take the comments from the chairpersons. Could we hear from Dr. Razia first about, Dr. Razia, can we have a comment from you, please, about the webinar? Dr. Razia Kurejo?
Yes, can you hear me?
Ma'am, you need to unmute your mic, please.
Yeah, we can hear her.
Yes, can you hear me?
We can hear you.
Yeah, we can hear you.
Okay, Bismillahirrahmanirrahim. On behalf of SOGP.
Ma'am, we can't hear you. Can you unmute your mic?
Yeah, we can hear you.
We can hear her. We can hear her. Her mic is unmuted. We can hear her.
I think you to put up your
Yes, I am listening. Yes, I am listening you.
I'm so sorry.
Yes. Can't you hear me?
Yes, we can hear you now.
Okay. Hello?
Yes,
Are
ma'am,
you
we can
listening?
hear you now.
We can
Professor Razia, we can hear you. We can just go
Okay,
on.
okay, thank you. So, Bismillahirrahmanirrahim. On behalf of SOGP, first of all, I would like to congratulate the first of the moderator for having this session, conducting very good session. All the speakers for their nice, very informative, very excellent presentation of the topics. As far as Dr. Rubina Swell's concerned, domestic violence is problem of all of us, as well as the developing or the developed world. And she talked about this, so I hope she is the executive member of the SOGP. So on the platform of the SOGP, she will conduct the workshops, how to address the domestic violence, how we improve the women's status in our country. As far as the maternal mortality and contraception concerned, both are going together. Maternal mortality is going, rate is going on and increasing, and the causes are the same all over the developing countries. In Pakistan, we are trying to reduce the maternal mortality. If we increase the contraceptive prevalence rate, then we can reduce the maternal mortality. So these presentations were very nicely presented in this SAFOG session. And all the panelists, I am thankful to all of the panelists who have given their precious time to be here in this SAFOG session. And Dr. Yusuf Latif, thank you very much for conducting this session, because this is a good way of connecting each other in this COVID situation. We can't conduct this. This is the first SOGP virtual symposium. We were supposed to do the international biennial conference on these dates, but due to this COVID situation, we have to switch over on this new innovative modes of the professional development to virtual webinar. So I think this is a good opportunity for all of the SAFOG regions to interact with each other, to share the problems and get informative knowledge from you all of us. Thank you so much for being here.
Thank you, ma'am, for your kind support and kind words. Can we please hear from Dr. Firdausi Begum, her comments about the webinar, please? Professor Firdausi.
Thank you so much. First of all, I must congratulate SOGP for organizing such an important program and selecting the topics very rightly. Professor Rubina Sohel, as usual, has touched the problem of gender-based violence very elaborately, and I think I should say, and very specifically as well. If we look at the newspapers of our region recently, it's loaded with gender-based violence. I can speak about Bangladesh. It's horrible. It's horrible. And also I have seen in India, Pakistan. I think it's enhanced by the COVID situation as well. There are multiple issues for this. There are many factors which may have increased in the situation. But I think all of us should take it very seriously, because if you think in the perspective of the victims and their family, it's such a tragic situation and such a, what should call it, it's an injustice. It's a total social, a political injustice. So it has to be, I think I'll appeal to all the societies to take it very seriously and have specific activities how to face them. I can share that we started acting from Bangladesh very early. I think in 1995, we started producing manual against violence against women. And at that time, UNICEF had a study in Bangladesh. And that study, that what is the root cause. So one of the things which struck my mind, and I think that's a very good intervention as well, that the adolescent boys, they are most sympathetic to their mother's role, you know, because they are beaten by their, they don't like that their fathers beat their mothers, their mother is such an awful situation, but these adolescent boys becomes the perpetrators later. So can we intervene? Can we make this soft heart making rational so that this doesn't happen? And I should not only blame males for this, they're famous, we have to intervene, and male participation is very important for empowering women, because I always say, because of my father, maybe the most important factor is my father's very strongly behind me to be in this position. So that is very important as well. Regarding MMR, maternal mortality, and Dr. Sadia has touched upon a very specific aspect of this death related to abortion and the role of the cat regarding this. And this is very important as well. And I have seen that there was one question coming and Dr. Sadia has answered that when the next WCAT workshop is going to come. So I think this is also again very important, that the rules, the say abortion law, if you look at the region, I think India and Nepal has very liberal abortion law. I think Nepal has the most liberal in the region. But my question is, does that solve the problem? It may come in other way. We see that there's female feticide is coming up in the picture. So the India has a very complicated situation now. One goes up and the other cuts it down. So basically, it's the social norms which has to be changed. And somebody said it should not be the norm, but the social structure may be important. Because the simple law which we have, that to save the women's life, it can be manipulated to as long as possible. So it's how we behave and how we take it, that is the important part. And I should congratulate my president of our society, Professor Samina Chaudhry, for elaborating our very successful contraceptive program in Bangladesh. And I should say that contraception and the regulation or empowerment of a woman over their fertility does not only reduce maternal mortality, it improves the quality of life as well in every aspect. So we, as a region, we have to look at it, because there are many countries which are sort of lagging behind, and the countries who have reached the goal should try to sustain and go up. So finally, let us have a vision and to look at the women not only just as the female gender or a weak part, but as a human being. So that's our challenge, that the female should be treated as human being with potentials to use their brain, not only serving, because so much capacities are going in the grave without being unutilized. So I appeal of all of us, and we should reinforce our commitment. So to work in the women's health, and from SAFOG side, I think we have all the desire to do that, and we'll work in unison to achieve our goals. Thank you so much.
Thank you so much, Dr. Dossi, for your valuable comments and discussion. Now I'll request Professor Farooq Zaman to give his comments about the topic and the webinar. Thank you.
Well, thank you very much for inviting me to participate in this.
So kindly unmute yourself.
Yes. Can you hear me now?
Yeah, Professor Farooq, we can hear you.
Yeah.
Jamal, sir, yeah.
There's something wrong with Mariam's audio system. She can't hear most of the people. Anyway, thank you very much. I think all the thanks to the organizers, to SOGP and SAFOG for this webinar have been expressed very elaborately. And what remains for me is to thank the organizers for bringing us all together. And I, for myself, can say that it's been a great opportunity of learning from so many people, and most of all, for getting a face-to-face meeting with so many friends and knowing their welfare and having the opportunity of exhibiting my own welfare to them. It's been a really exciting session. It was very nice to see Dr. Lubna Hassan here, Dr. Narendra, Professor Samina Chaudhary, who gave such an excellent presentation about the contraceptive situation, Professor Ferdowsi's comments, and so were Professor Razia Qureja's comments. Rubina was very good with her presentation about gender-based violence. And so was Sadia Pal. She kind of took over the meeting completely. And she's so very well entrenched into this value evaluation and that framework, which I think is extremely important. All of us need to sit back and evaluate ourselves about what our values are and how are we going to apply them. So these are excellent presentations. Shyam Desai is a little too busy, it seems. He just came late, but it was good to see him. And well, Professor Sir Sabaratnam, he always is the great support for these regional meetings. And on behalf of SAFOG and SOGP, I would like to extend our special thanks to him for making this weekend available to us and being there. Your smile is always very encouraging, and it's good for us. Thank you very much, Arul, because you always are and will be Arul for us, and only at formal occasions will you be called Sir Sabaratnam. Thank you very much.
Thank you so much, sir, for your valuable comments. My question rather is from Dr. Arul now. Sir, what if we are not able, is 10 years enough to actually achieve these SDGs? What is your take on that? And what if we cannot achieve them in 10 years? What would be the way forward? So,
you'll 10 more years.
It's a good question, but first I would like to start by thanking the Society of Obstetricians and Gynecologists of Pakistan and the SAFOG for inviting me, and Farooq for your kind comments. Let me just give you some comments about what I learned over the last 2 hours. First, from Rubina. It was an excellent talk on gender-based violence, and it reinforces something, that the responsibility lies with everybody. the father, mother, children, society, government, with everybody. Unless everybody works, this cannot be. And the bottom line, which came to me, was education and empowerment. And these are two important things if we had to really alleviate the problem. Sadia's talk again, excellent. And it reminded me of the situation I was facing in Ireland. And there are two things which comes to my mind. One is actually those who do not support legal abortion are indirectly supporting illegal abortion. So there's no question we had to really get this into our hand. Secondly is that there's no country in the world which has imposed legal sanctions and got rid of abortions altogether. Every country, despite restriction, it comes. So it came out very clearly that wonderful work you're doing. Thank you. And Samina, thank you for acknowledging my role with the OG Society of Bangladesh, and very good talk. And this brings out the essence of what is happening to reduce maternal mortality in the short term. Contraception will reduce by 30%, abortion by 15%, and the rest is all emergency obstetric care. And if the society is functioning well, then it'll be a wonderful thing to reduce maternal mortality and bring gender equality. But now, Mariam, to your question. The question really is a difficult one. And I think Narendra touched on it as well. That is, the panel discussion gave the answers on various accounts by Yusuf Latif, saying what and what we can do. I think as a group, we had to think about short-term and long-term solutions. And the long-term solutions are education, empowerment, or eliminating gender-based violence. These are long-term solutions because society can't change overnight, and we have to work on education. And if it goes beyond the SDG 2030, it doesn't matter because we are looking at our daughters, the granddaughters, and so on. So we have to keep working. That's a long-term solution. If we can have good education, empowerment, and eliminate gender-based violence, then we will win the battle. In the short term, of course, we have to look at what the talks gave, which is the three low-hanging fruits, which is contraception, abortion, and emergency obstetric care. It was a wonderful seminar for excellent lectures, excellent discussion. And I think generally I learned that we had to look at short term as well as long term. So we had to keep on working. That's the final message. Thank you very much.
Just one point. Sir, sorry, I must apologize. I forgot to acknowledge you because Sir has rightly said, without a rule, SAFOG is incomplete, basically, because we led us to think about broadly and intensely. Thank you, sir, again, and especially from Bangladesh side for working with us. And you are always welcome. And for all the panelists and the SAFOG people who are here, I think you got the mail that we are trying to organize the executive committee meeting on 24th at 7 p.m. Bangladesh time. And please be prepared because yearly we must meet once. So I am taking this opportunity to invite all of you to be joining to this meeting and get prepared. Thank you so much.
Thank you again, sir, for answering the difficult question. So now we'll take some questions from the participants that were asked. My first question is directed towards, this is I think for Dr. Sadia. So the participant wanted to know what is the value of the husband if he prevents against family planning. So what should be your take on that? I think we're talking about consent from husband for contraception. If the value of the husband is that, she should not use contraception, even if she wants to, how would we tackle that value of the husband?
Well, you can only try talking to them and go through the pros and cons. You can't force a couple to use contraception. And but on the other hand, it is she who gets pregnant. This is what I tell my patients or clients, that he's not going to get pregnant. It's you who's going to get pregnant. She's had 3 or 4 previous C-sections and really horrible adhesions and still refusing to have an IUCD inserted or have a tubal ligation. So, but you know, it might work. That kind of argument might work, but it doesn't always. It's very hard to change the mentality. So, at the end of the day, it is a human right of that woman. You know, her health and contraception is really, it's about her body and it's her right. But it doesn't always work that way. And we can't force the man, we can't force the husband, because in our society, I can't speak for other countries, but in our society, especially with the feudal mindset, they often will use that to go and marry another woman. Okay, or she can't have babies anymore, as if marriage is all about having babies and nothing else. So I'm sorry, there's no clear right or wrong answer there.
Thank you, Dr. Sadia. My next question is from Dr. Udupi from Sri Lanka. So what is the situation of gender-based violence in Sri Lanka, and is there any legislation for that in your country? I think he's left.
I think Dr. Ratnasri has left. I don't see him in the panel.
So
So maybe we should wrap up, because we're already over our time, you know.
Mariam, you have to unmute yourself, please.
Mariam, you are mute. We can't hear you.
Jai?
Mariam, you are mute.
Is there any burning question?
Yeah. So my next question is from Dr. Lubna. Is there any legislation existing for family planning, and can a law help curb this problem in Pakistan or other South Asian countries?
I don't think there's any legislation. I mean, you can't stop people from having as many children as they want. You can recommend and you can advise. But for family planning, there have been various programs through the media, Bache Do Hi Achhe, and that sort of thing. Then they went to 4. But the slogan even from WHO is family planning for health. But when it impinges on the health of a woman, that she cannot, I feel that, any preventable maternal mortality is the biggest domestic violence, and that should be punishable. But unfortunately, there is no sort of legislation for that. We are trying to make maternal mortality a notifiable event, just like TB is, and like any other thing, so that we can track it. But that's as far as we can go. And I think in KP, we've already tabled the bill for making maternal mortality a notifiable event. But contraception, as far as I know, there is no legal binding on any family to limit the number of children they have. If there was, there may have been, some sort of a, lid on the thing. But the way our children our families are breeding like rabbits, it's obviously they're allowed to do it.
I think, Lubna, the question might have been, correct me if I'm wrong, might have been that supposing a woman wants contraception, but the husband doesn't, So in our setup, we tend to take the husband's consent also.
No, the husband's consent, even the WHO says, because babies are sort of, it takes 2 to tango. So obviously, although it is the woman's body and she is receptive, that is where the inequity, not even inequality, but where the gender inequity comes in, that a woman by nature is expected to do much more and put up with much more. And yet she's treated equal. It shouldn't be equal. We should definitely be given more weightage for, what we go through. But that's not the way it is. So that permission for sterilization, I think there is no permission for contraception per se, but there is permission for sterilization, which is the permanent tubal ligation. For that, you need a signed consent from the husband, if that was the question. But for contraception, you don't need the husband's permission.
Regarding legislation, sometimes it's like sort of boomerang. And the example is in India. I think Narendra is here, but Narendra we clearly remember Dr. Indira Gandhi failed in election because of the forceful, the mandatory ligation of that program. So basically, it's sort of boomerang. People react, and it's obvious that there should be no coercion. So law doesn't help here. One of the things what Bangladesh has done, you know, this is a Muslim country, and there is a sort of a sort of people text that this is forbidden in religion. So that cycle has to be broken. And what should I say, that one of our imams had helped us. He said that in Quran, there is nowhere it is written that you should use contraception, but though nowhere it is written that you should not use contraception as well. So this is clear. When there is needed, the people can use it. And in life-saving conditions, contraceptive is the must. It's the law of Quran as well. So I think that sort of, Professor Samina Chaudhary has shown that book is in Bangla, that religion, Islam in contraception. So Bangladesh has written very good Bangla books, and this is in website available in the websites. And we often ask the imams during the I think khutbah and etc. to tell about that this contraception is not absolutely forbidden in Islam. So I think that is one of the things which can be done to reduce this non-use of contraception. Thank you so much.
Thank you so much for that valuable suggestions. Now I'd like to conclude and thank once again everyone for their patient listening, and I hope that discussion from today has added value to your learning. Now I'd like to officially thank all the patrons, chairpersons, the chairs, the speakers and the panelists for their taking out valuable time for this activity and giving us very important suggestions, and thank you for your contribution and time. I'd like to thank SOGP for giving us this opportunity to speak here and meet again in this area of COVID and speak about some very important topics, especially Dr. Halima and Dr. Razia for your support. I'd also like to thank Sami Pharmaceutical for their support, and Orbit for making this possibility and marketing the event, as well as having some last minute help with the presentations. And I would really like to thank all of you again for your time and patience. And now I'll just play a video in the end from one of our previous SAFOG activities, and I hope you enjoy it. Thank you again for your time. Thank you. Stay safe and stay healthy.
Thanks, Yusuf, for fantastic conduction, and Moriam also. Thank you so much.
Thank you.
Thanks.
Hello.
Did we play the movie? No one buy to watch.
I think again we have trouble having to run the video.
Well done. Well done.
I just heard a joke today in which they said, whatever you give to a woman, she does not return that, but she doubles that and then it returns. If you give them sperm, they'll give you a baby. If you give them grocery, they'll give you food. If you give them a house, they'll make it a home. But if you give them frustration, then you know where you're heading for. So
Boy.
Yeah, that's true.
Good, good.
So let's, yeah. So ahead.
Turn the volume.
ठीक नहीं आ रहा.
Wow. Fantastic. Yusuf and Rubina, I think you have to be sort of working more for this executive committee meeting. And of course,
Yeah,
everyone,
we will do that.
but these two key persons. Thank you so much. I'll be after you for
If
some
you
time.
send
Thank you
the
so much.
agenda to all of us well in time, we'll be better prepared for it.
Yeah. Lubna,
That's right.
as Vice President, please put on your roles and comments so that we can have a successful
Agenda. I can
1
talk
month's
on
time from now.
We need an agenda so that we stay focused.
Yeah. Agenda is coming up, and Yusuf is going to serve that, I think, tomorrow maybe. Okay, see you. Fazar is here. I'm in Canada, so just 10 minutes for
You enjoy your
from
sleep.
sunrise. Okay, see you.
Okay.
Bye-bye.
Bye. Stay well.
You too.
ये क्या हो रहा है?
Namaz?
Well, then thank you, everybody.
Good job, and thank you.
Thank you. Bye. See you, Rubina.
Very much. Thank
Bye bye. See you.
Bye bye.
See you.
Thank you, Professor Arul. Very nice of you.
Okay, he's probably gone.
Okay. Arul, bye bye, and everyone. Thank you. Goodbye.
Bye. See you, Rubina, next weekend.
See you. Yes. Hopefully.
Bye bye. Why? कहाँ जा रही हो?
कोई काम नहीं.
कहीं नहीं जा रही. मैं यहीं हूँ. I am there to receive you.
मैं आ रही हूँ तो फिर तुम कहाँ जा रही हो? मिलेंगे तो.
No worries. No worries. I'll be there.
I'll find
Please
you.
have a
Don't
good
worry.
meeting. Okay.
I'll-
Take care. Bye,
Okay.
everybody.
Thank you. Thank you.
Thank you. Thanks, everyone. Thanks, Yusuf. Thanks, Mariam. Lubna.
नहीं चले गए आखिर खत्म हो गया. ये अवैस साहब को भी कह दो थैंक यू. अवैस चलो बस ठीक है.
सर मैथ्स तो बहुत ही मुश्किल है.